Hello, my name is Brandon Olai. I'm an athletic trainer with NovaCare Rehabilitation, and I work at Lincoln University in Oxford, Pennsylvania. I'm currently a doctorate of athletic training student at Temple University in Philly. Today I'll be talking to you about the best practices for evaluating a suspected labral tear of the shoulder. Today's objectives are: what is the best practice for clinically evaluating a shoulder labrum tear? What are the best special tests to use? And what is the best diagnostic imaging tools to use to accurately diagnose this injury? A quick overview of the anatomy. The labrum is a fiber structure attached to the edge of the glenoid in the shoulder. It's made up of fibrous cartilage and some dense fibrous collagen tissue. Its purpose is to increase contact area between the glenoid and the humeral head. 50% of the long head of the bicep originates from the superior labrum. The superior labrum is typically more loose and mobile than the inferior labrum, which is more tightly attached to the glenoid rim. The Snyder classification is used to help with the classification of this injury because the labrum doesn't tear in one way. It has multiple ways of fraying, tearing, or being injured, and it has to have a concise way of classification. Type 1 tears are fraying of the superior labrum with an intact bicep. Type 2 are detached superior labrums and a detached bicep anchor. Type 3 and 4 are both bucket handle tears of the superior labrum. Type 3 being no bicep involvement, and Type 4 being the bicep is involved. Slap tears are very common injuries to the labrum and a strong or very common cause of shoulder pain and instability. A study from 2002 to 2009 reported that there was a 238% increase in slap repairs compared to a 125% increase in all other orthopedic procedures. This injury can be very debilitating for an overhead athlete, and there's also a study done which kind of ties into the study from 2002 to 2009. There's a high prevalence rate of middle-aged patients getting diagnosed with labral tears with asymptomatic shoulders, meaning that on diagnostic imaging, it showed that they had a labral tear. However, they weren't experiencing any symptoms or any decrease in activity levels or any disability with activities of daily living. So typically, the mechanism of this injury can be from a single traumatic event acutely, or it could be a chronic overuse injury and caused from repetitive microtrauma. If it's a single acute event, it's typically from a falling on an outstretched arm, motor vehicle accident, direct blow to the shoulder, or from a subluxation or dislocation episode. Repetitive microtrauma is typically caused from throwing or pitching, or any overhead activity like serving in tennis, or serving in volleyball. So for your clinical evaluation, when this patient comes into you, you want to make sure you take a thorough patient history. You want to find out what their job or what their sport is, how old they are, and what level of disability this injury is causing them, and of course their mechanism of injury, if it was acute or if it was kind of a chronic over time ordeal. Next, you obviously want to test their range of motion and their strength, and then you would get to your special test. Your special tests are going to be pretty much from this list. These are kind of in the forefront of the research and literature today. The dynamic labral shear, active compression, which is also known as O'Brien's test, speeds test, the pronated load test, bicep load 1 and 2, resisted supination external rotation test, and Jurgensen's test. The diagnostic imaging typically used is MRIs or MRAs. Wood and their colleagues used these tests to investigate activity of the long head of the bicep, which attaches to the labrum. So, according to their results, the speeds test, active compression, or the O'Brien's test in the part where the palm is facing upward, and the bicep load 1 and 2 both elicited good activation from the long head of the bicep, which can be helpful being that it attaches or originates from the labrum, and if it causes pain from these provoking tests, that it could be kind of indicative of a labral tear. And the other tests had poor activation of the long head of the bicep. As mentioned before, the dynamic labral shear test is kind of getting more forefront in the literature as well. I did find one study that kind of went over the sensitivity and specificity of it of 78% and 51% respectively. And here's a quick video on how to perform this test. So you'll see here, elbows flexed 90 and shoulders abducted to 120 degrees in the scapular plane, externally rotated to the limitation of the patient, and you're just going to guide it through maximum horizontal abduction. And then this can produce painful clicking or catching or popping, and it could be indicative of a labral injury. Next, Gizmerovic conducted a systematic review on the diagnostic test performance of shoulder tests for the labrum and other shoulder pathologies. However, we're focusing on the labrum here, and they gave this top list of the specificity and sensitivity for all these tests according to their systematic review. From that systematic review, I'm going to go over these top 4 special tests and give you a quick video on how to perform these tests for when you are evaluating a labral injury. So first we're going to go over the compression rotation test. As you see here, the patient supine, you're going to abduct their arm, add an axial load to the humerus, and externally, internally rotate, trying to elicit some pain, clicking, or catching in that joint. Next, we're going to go over a quick video on the Speeds test.
Speeds test is performed by having the patient forward flex her arm against your resistance with the arm supinated. Pain indicates biceps tendon or labral pathology.
As you saw in that previous test, you also would want to palpate the bicipital groove while resisting forward flexion of the arm and the shoulder to potentially feel any clicking or popping under your fingers, and to see if your palpation there can elicit pain as well. Next, we're going to go over the Jurgensen's test. Which is typically done for a bicep injury. However, due to its attachment to the labrum, it can also help with labral diagnosis and injury evaluation of this. As you see, the elbows flex at 90 degrees. You're resisting supination of that patient, and it could either make pain over the bicipital groove, or there could be some subluxation of that long head tendon as well. And it also could elicit pain in the shoulder where it's attached to the labrum if the bicep is involved in a labral tear for those type 2 and type 4 injuries. Next, we're going to go over, and lastly, we're going to go over the crank test. As seen here, it can be done supine with the patient lying on the table. You abduct their arm in the scapular plane to 160 degrees, and then you provide an axial load across the humerus and internally, externally rotate that arm. And you're trying to reproduce pain by clicking, popping, or any reproduction of the symptoms. And as mentioned in the text, it's similar to the compression rotation. However, it's not done at 90, it's done at 160 degrees. So, now that you have these tests and you have some positive tests, what's the next step? Obviously, you want to talk to your team physician if you're in athletic training in the high school collegiate setting or professional setting, or you talk to an orthopedic surgeon, and they're most likely going to want to get some imaging done. According to the systematic review and meta-analysis done by this team of authors, it was found that MRAs were more effectively able to diagnose labral tears more accurately than MRIs. So in the event, you would want to get an MRA for your patient to kind of accurately diagnose their injury to make sure everything is okay. So putting it all together here, first you obviously want to get a thorough medical history to see what you're dealing with, if it's an acute injury or if it's a repetitive, chronic, over time thing that's gotten worse and that they're coming to you finally when they can't take any more. You want to use strong special tests which are going to be recommended by the research, which is a compression rotation, Speeds test, Jurgensen's test, and crank test. In the event that you need imaging, you would strongly suggest to get an MRA done. And then lastly, you want to get orthopedic consultation in the event that their patient may need surgery and arthroscopic intervention to help repair and heal this injury to make them be able to get back to their daily life. There are the references for this presentation, and I'd like to thank you for your time, and I hope you enjoyed it. Thanks again.